Now about the Dacron, polyester, polypropylene, polyethylene, Teflon coated or impregnated Dacron, polyester, silicone coated Dacron, polyester. It is a braided type of suture material and it exhibits greater tensile strength and knot holding ability. Because of this polypropylene and polyethylene quantity, this the suture has a knot holding ability and it does not produce any tissue reaction. And but the main disadvantage, the patient cannot afford it. Sometimes you have to see because it is expensive. Now we can see that the suture material which is non-absorbable, which includes surgical silk and expanded polytetrafluoroethylene. And the indication is it is generalized use in the keratinized tissue. So it is the oral suture and it is the most widely used sutures, the surgical silk, and it has the capacity to strength and it's most commonly used suture and it is used for the all generalized suturing. And absorbable sutures, which includes catgut. Catgut includes two types of suture, plain catgut and chromic catgut. It is used for the general purpose. It can be used for the mucogingival surgery also and flap surgery also. And the synthetic fiber, including the polyglactin, the 910, the coated vicryl, and polydecaperon, that is monocryl. So basically, there are two types: natural, the catgut, and synthetic fibers. Multifilament and versus monofilament type of suture materials. So, what is the basic difference between the multi filament and monofilament suture material? Is that the several filaments twisted and braided together. Single strand of the material. It increases the strength and flexibility. And what happens basically in monofilament, there is a single strand of material. It passes smoothly into the tissues. And what happens with the multifilament, because of the braided and the several filaments which are twisted together, it has the strength and it has the flexibility. Increased incidence of infection causing invasion of bacteria into the braided crevice and also cause the increased friction against the tissues. So what happened with the uh, multifilament? There can be the less chances of uh, uh, in monofilament, because of the single filament, there are less chances of infection. In multifilament, there is more chances of infection because the multibraided, the micropores are created, and this micropores can be directly invaded by the bacteria, and they can be present in the oral devices. Biologic response of the body to the suture material. So you see that the surgical needles have three components: the eye, the body, and point. So what happens? What is the biological response of the body to the suture material? So suture material is basically it is fit into the surgical needle. So with the surgical needle, we are going to suture back the flap. So surgical needle has three components: eye, body, and point. Eye can be closed and swatched, and the shape of so eye can be round, oblong, and square. Eye needles are dramatic needles, and swatched sutures are adramatic needles. So what happened with the basically the eye needle and swatched needle? It is why it is adramatic, because it does not has eye. So the needle does not need to the pass through the eye, and it is directly swatched into the body of the suture needle. And with the eye type of needles, they are the traumatic needles. Why they are called as traumatic needles? Because the suture material is passed into the suture material is basically passed into this eye of the needle, and then you have to form a knot. So basically, this increases the diameter of the needle also, and this also because of the knot, it can cause damages to the mucosa and gingiva. So it is also called as a traumatic type of needle. And the body. What happens with the body? It is the widest part of the needle and it is referred to the grasping area. Why it is called as the grasping area? Because with the help of the with the help of the suture needle, with, where we hold basically the suture needle from which area. So the body of the suture needle is holded with the help of the uh, this knife, and the cross sectional configuration of the body may be round, oval, and oval, side, flattened, rectangular, triangular, and trapezoidal. And the point is, or the tip can be conventional or reverse cutting, and the tip can be cutting round or blunt, that triangular in cross section. Suturing. Selection of the type of the suture material and needle is dependent on the tissue type and the thickness, location in the mouth, ease of handling, cost, and planned time of suture removal. Technique selection is also determined by final flap positioning. So selection of suture material basically depends upon the location of where you are going to perform a suture, and where the suturing, removal of the suture material will not be difficult. Technique selection is determined by the flap positioning, or you are going to perform the mucogingival surgery, you are going to elevate the full thickness flap, you are going to reflect the partial thickness flap. All this type of technique basically depends upon the which type of suturing material you are going to use. So what are the goals of suturing? See, this is very important. And what is the goals of suturing? First goal, one most important goal of suturing is hemostasis. Hemostasis means control of bleeding, and at sometimes ligating artery with the suture material also helps to control the hemostasis. So first important is thing is hemostasis to control bleeding at the surgical site. Second, to permit healing by the primary intention, because the two flaps or anything with two margins of the flaps, when they're placed together, the healing will be primary intention. If they are at a distance apart, then the healing is done by the secondary intention. And third is to reduce the post-operative pain. And fourth is to permit the proper flap position. And fifth is your prevent bone exposure, result in delayed healing and unnecessary resorption. As we all know that the suture materials which we use to in the periodontal flap surgical or mucogingival procedures, we are going to reposition back flap over the area. So what happens with the flap? We are going to cover the entire bone. And why we are exposing the flap? We have already discussed for the accessibilities to the underlying calculus or any bone defect. So you are going to expose the bone. So bone is directly in contact with the atmosphere. So what happens because of the desiccation and desiccation of the bone and the temperature changes? Sometimes what happened, the bone started resorption. So what happened whenever the bone is exposed, there can be some amount of resorption. So when we are closing that suture material flap with the help of suture material, and so it will help in unnecessary resorption of bone. So what is the principle of suturing? The principles of suturing, the suture techniques. So the principles of suturing, what happened? The principles of suturing is to control the bleedings. The principle of suturing is to control the bleeding, and we are going to discuss the all the things. What should be the flap design, and what should be the design of the your incision, and we are going to discuss every point. First, we'll discuss about the suture techniques. So interrupted, sling, and continuous suturing. So what happened in the interrupted suture technique is basically used for the closure of vertical releasing incision and interproximal areas, replaced coronally and position flap closures. So what happens with the interrupted suturing? You can use the if you are placing a vertical incision and the interproximal areas which are because the surgically elevated, so they are going to place back in the same position and vertical releasing to heal by the primary intention. Second is your sling suture, allow the separate facial and lingual flap positioning in isolated areas. And third is your continuous sling. It basically use what happened. What is the main advantage of the continuous sling? All the flaps are basically they are thread in between the only the one suture material and with the one knot. So all the interdental spaces of the multiple tooth or whole section, or you can call the quadrant, it allows the closure of both buccal and lingual flaps with the single uh, tie. Double continuous link, it is used for the apically positioned flap closure. It also allows the buccal and lingual flaps to be closed independently. So basically what happens is if there is loosening of the knot for the buccal areas, it will not hamper the knot in the lingual flap. Now the external mattress sutures, what happens? It reduces the amount of suture under the flap and allows papilla closure over the osseous graft. Without the suture running through the graft, it enhances the positioning of papilla. See what happened. Whatever we do, we know that the some amount of suture material is present under the flap and some amount is over the flap. So what happened? When we are using the regenerative procedures, we are going to place a bone graft over there. So we don't want any foreign material to come in between the bone graft and the flap, because what happened, to promote more osseointegration and osteoconduction, we don't basically need a foreign material to a foreign material to separate the bone graft material with the flap. So, for basically this type of suture material, suture technique is used for the regenerative procedures, because we want the less or no foreign material through the graft. So, it is used in the capillary regeneration flap. It is used in the bone augmentation technique using the bone graft. And even you can use this technique while using the GTR membrane, guided tissue regeneration membrane. Vertical technique, basically it is used in the, what is the indication? Main indication is your narrow interdental spaces, and horizontal is used for the wide interdental spaces. Vertical, basically when the interdental space is too narrow, we cannot perform the horizontal one and we cannot perform the interdental, so we can use the vertical technique. Internal mattress. Internal mattress, anterior, basically it is used in the anterior interdental areas. Knot may be tied on the lingual and palate to improve aesthetics, and edentulous area in combination with the interrupted sutures to reduce tension on the incision line. So what is the main advantage of the internal mattress? Basically, it is like it helps to decrease the tension on the incision line. So the margins are not everted, and the healing will be done by the primary incision, and they are not produced after healing any rubbed margin. Suspensory type of technique, it is used in the coronally advanced lab, and basically the suspensory suturing technique is used for the root coverage techniques. Anchoring, it is used for the guided tissue regeneration membrane, because you are going to anchor the GTR membrane to the root surface. You are going to adopt the guided tissue regeneration membrane towards the root surface. So we want the GTR membrane should not be displaced. So we want to anchor this membrane under the flap with the tooth material. So this type of suture material is used. Laurel loop, it is used for, again used for the GTR membrane to close over an interproximal barrier membrane. So this type of the surgical techniques we are going to surgical techniques or suturing techniques we are going to use for the different purposes. Now about the surgical knots. What are the surgical knots? It can be of square knot, surgeon's knot, and Greenleaf's knot. So what happened in the square knot is basically wrapping the suture material along the needle holder once in opposite direction between the ties, and at least 3 ties are recommended. So square knot is basically you are going to tie a knot, and one in, like you are going to place a one in clockwise direction, then one in anti-clockwise direction. What is surgeon's knot? Surgeon's knot is your two throws of suture around the needle holder on first tie, and one throw in opposite direction in second tie. So you are going to make a 2 rounds of suture material for first tie and one throw in opposite direction in the second tie. Granny knot, tie in one direction followed by a tie in the same direction, and the third tie in opposite direction to square knot and hold it permanent. Okay. So if you're going to give a for granny knot, if you're going to give two knot in clockwise direction, and the last knot will be in anti-clock direction, and it will be your permanently knot. Wound management. So what happened with the wound management? Crucial aspect of periodontal surgical therapy and post-operative wound stability is paramount for the desired surgical outcome to be achieved. So what happened? Why the wound management is so important? Because like we are performing again, when we are going to perform a surgery, we are creating a surgical wound. So we are going to cure the disease also, and we are going to cure that surgical wound. So basically, the wound stability is the prime importance, and the success of surgery basically depends upon this wound management of it. So you can use the periodontal dressing or pack, which is a protective material, which is applied like over a wound created by a periodontal surgical procedures. So what happened with the when we use the periodontal dressing to protect the wound post surgically to obtain and maintain a close adaptation of mucosal flap to the underlying bone, especially when a flap has been apically repositioned and for comfort of the patient. So what happened? Why we are going to place a periodontal dressing or pad? Because what are the uses? To protect the wound post surgically and to obtain or it maintain a close adaptation of mucosal flaps to the underlying bone. So there will be no dead space, then there will be faster healing, and because the one pack is covering your surgical area, so it can basically uh, protect your surgical area with the two heat or two cold substances which we are using to heat during the at the time of your surgery. What are the properties of the periodontal dressing? The periodontal dressing, it should be soft, and but it should be have enough plasticity and flexibility to felicitate its replacement in operated area and to allow a proper adaptation. And it should harden within a reasonable time. After setting, the dressing should be sufficiently rigid to prevent fracture and dislocation. The dressing should be soft but still have enough plasticity and flexibility. What do you mean by this? Basically, because um, periodontal pack mostly after the surgery it is used in the dentulous area. So you are going to, and this periodontal pack fills that area with the help of mechanical retention. No chemical retention is required. So what do you understand by the mechanical retention? Means you are pressing the periodontal pack through the interdental areas. So basically it forms a bond between the interdental area and the periodontal pack, the mechanical bond. So it should be sufficiently flexible so to adapt between the operated area. And it should hard with a reasonable time to allow the with the workable consistency, but it should hard after some period of time. After setting, the dressing should be sufficiently rigid to prevent fracture and dislocation. Smooth surface after setting to prevent excessive plaque formation. So what happened if there are granular surface present after the setting? So what happens? There will be a rough surface. There will be more deposition of plaque. There will be deposits of the food debris also, and the material alba also. All what you are going to eat, it will deposit on the periodontal pad. So it after setting it should be like plain. The dressing should preferably has antibactericidal properties to prevent excessive plaque formation, must not detrimental interfere with healing. So what happened? Dressing bactericidal होनी चाहिए क्योंकि because there will be a mechanical bond between the periodontal pack and the surgical area. So what happened? material and all the other oral debris, it will accumulate on the surface. So because of this bactericidal property, it does not let the accumulation of plaque. It should not interfere with the healing. This is the prime thing. So now the types of periodontal dressing. The first is zinc oxide eugenol pack. Based on the reaction of zinc oxide and eugenol, it is developed by the Watt in 1923. It is also known as Wonder pack. What is the composition of zinc oxide eugenol pack? It is zinc oxide and eugenol, zinc acetate, that is accelerator, asbestos binder, and it is also used as filler. And but what is the disadvantage of asbestos? It has been found that it is associated with the lung disease. And tannic acid, it is used with the liver damage. So what happened? The asbestos, it induces the lung disease, and tannic acid also, it causes the liver damage. Non-eugenol packs, based on the reaction between metallic oxide and fatty acids, its composition, it is applied in the two tubes in the form of zinc oxide, and the principal amount is, the principal thing is your zinc oxide, and second is your oil of plasticity, and gum, it is used for the cohesiveness, liquid coconut fatty acids, rosin and chlorothiamol, which act as a bacteriostatic agent, cyanoacrylates and methyl acrylic gel, and these are the example of non-eugenol packs. So this is the composition of the non-eugenol: zinc oxide, oil of plasticity, gum, liquid coconut fatty acid, rosin, and chlorothiamol. Preparation and application of periodontal dressing: zinc oxide pack when mixed with the eugenol and non-eugenol liquid on wax paper pad with a wooden spatula. Preparation and application of periodontal dressings: zinc oxide when mixed with the eugenol and non-eugenol liquids on the wax paper pad with a wooden spatula and tongue depressor. So powder is gradually incorporated into the liquid until the thick paste is formed. Co-pack preparing, it is prepared by mixing equal length of paste from accelerator and base until a paste with the uniform color form. A capsule of tetracycline powder can be added at this time. Packed then placed in water at room temperature. 2 to 3 minutes. After 2 to 3 minutes, paste loses its stickiness, and 3 to 5 minutes it can be handled and modeled and remain workable for 15 to 30 minutes. So what happened basically with the co-pack and the zinc oxide pack, the two lengths you are taking from the base and catalyst, you're going to mix till then uniform color should be achieved, and you can add a tetracycline powder to add a bactericidal or bacteriostatic property. Then you can dip the immerse into the room temperature. Then afterwards it is workable for 50 to 30 minutes. Then you can place it with the help of mechanical retention. The mix then rolled into the two straight ribs. End of one strip is rolled and back to the hook shape to fit around the distal surface of remainder of the tooth and brought over the facial surface and nicely adapted to the gingival margin area and interproximal area. Next strip, it is placed lingually, and when the two strips are joined forcefully interproximally, the area is covered with the tin foil to protect sutures. Bleeding must be controlled before the placement of pack, and area should be dried. Pack should not cover more than apical third of the tooth surface. Overextension should be avoided, and it causes irritation and tends to break off after asking patient to make all the functional and forcible movements. Pack interfere with the occlusion, it should be removed. As a general rule, pack should be replaced after 1 week after surgery. So it should not be cover more than apical third because it can interfere with the occlusion. What is instruction to the patient after placement of periodontal dressing? Importance of pack should be explained. If pack breaks, leaves the sharp edges and repose to office, Do not brush over the back. Instruction to the patient after placement of periodontal dressing. First of all, why the importance of the pack should be explained clearly, why the pack is applied on the area, and if pack breaks, leaving the sharp edges, they have to report to the office or they can come to the dental clinic. Do not brush over the pack. Use chlorhexidine mouthwash and come back after 7 days for pack removal. Findings at the pack removal. If gingivectomy is performed, cut surface is covered with the friable meshwork of new epithelium, which should not be disturbed. And if calculus not been completely removed, the red bead-like protuberances of granulation tissue will persist. This granulation tissue must be removed with a curette. After the flap operation, areas corresponding to the incisions are epithelialized but may bleed readily when touched, or they should not be disturbed. Pocket should not be probed. So you can see this type of findings after the pack removal or new epithelium. If the gingivectomy is done or calculus अगर remove नहीं हुआ है, then you can see the red bead-like protuberances of granulation tissue, and you can see the areas which are ready to bleed when touched, but they should not be disturbed, and the pocket should be. This is very important point. The pocket should not be probed. The facial and the lingual mucosa may be covered with a grayish yellow and white granular layer of the food debris that has seeped under the pack. Easily removed with a moist cotton palette, the root surface may be sensitive to approach or thermal changes. Fragment of a calculus delayed healing. You can see the root surface to be rechecked visually to be certain no calculus is present. So, repacking advice for additional week for patients with a low pain threshold who are uncomfortable when pack is removed, unusually extensive periodontal involvement, and with the slow healing process. Application of periodontal dressing. We have already discussed. Complications of surgery. There can be syncope, there can be hemorrhage. Hemorrhage can be primary, secondary, tertiary. Complication in the first week, persistent bleeding after surgery. There can be sensitivity to percussion. There can be swelling, feeling of weakness, post-operative pain. There will be sensitive roots and root hypersensitivity. So what happens basically when the general basic principles of periodontal surgery, it should be known because to perform an effective and safe periodontal surgery, every surgical procedure must have an endpoint in the mind because of the initiation of the treatment. With the current emphasis on the evidence-based periodontal therapy, scientific knowledge, when available, should become a primary driving force in therapeutic and surgical making decisions. Thank you.